Metastatic prostate cancer has experienced really dramatic shifts over the last decade with the advent of novel therapies and novel applications, including drugs like androgen receptor pathway inhibitors, chemotherapies, targeted therapies like PARP inhibitors, and radiotheragnostics. So really critical to this evolution is a determination of how we should best sequence treatments and really determining which patients are best suited for these given therapies. So to give us a little bit of a background, Dr. Vaishampayan, I'll ask you, how do we characterize hormone-sensitive prostate cancer and really think about the risk stratification for our patients?
So hormone-sensitive prostate cancer is typically how a patient initially presents. Within that, metastatic disease, conventionally we talk about metastatic disease when you see signs of spread outside the prostate on our typical imaging, which is CT scans and bone scans. So far, we have not quite made the switch, at least from a clinical trial standpoint, to use molecular imaging as a staging mechanism. Although a lot of decisions now are gradually being made more and more with the PSMA PET scans or some kind of molecular imaging techniques that will probably stage the patients to an advanced stage sooner. But the basic definition of metastatic castrate-sensitive prostate cancer would be where the cancer has spread outside the prostate and that patient has a normal testosterone level, which typically is considered about 150 or so minimum testosterone level, and the patient is just starting therapy.
Well, that's excellent. It's a really comprehensive and detailed overview. That leads me to my next question. So understanding the risk stratification approaches, how do we approach therapy selection in the hormone-sensitive setting, given the evolving landscape of available therapies? So Dr. Efstathiou, I'll ask you. Mm-hmm.
Well, thank you for that. And, I think that we all in this room and during the meeting voiced the fact that to this day, we do not have the markers that we should have, right? We don't have these prognostic and predictive markers that you have in lung cancer or in breast cancer. So we have to use the poor relatives equivalent, right? The surrogates, at least that have been defined based on some assumptions, which have to do with volume mainly, presentation, time of presentation. And these are poor surrogates because, of course, the progression of prostate cancer is a dynamic event. And the reason I'm saying it is you may be lucky enough to catch it where only on PET imaging, for instance, there are a few findings, but this may be a highly aggressive disease that is in the making. So they're not fail-proof. But having said that, that's the best we have right now. And the definition that started back in the day when we had the GLASS classification that started the CHARTED trial was mainly based on the number of metastatic lesions, the presence of visceral metastases. Those all would put you in a simplified way in the high volume category. And then you have the low volume category that may be more lymph node only disease or limited bone metastases. But then you also had a new definition that came about with the Latitude trial that looked at a high risk and low risk that incorporated there also the Gleason score. And on top of that, we know for a fact now that if the presentation is de novo and especially high volume, then you're looking at that prostate cancer that you want to put at your top priority on how to treat. So it's a number of different morphologic and tumor characteristics that you take into consideration. But then you have to take into consideration the patient characteristics, as we are always, when deciding the treatment, as we are at the end of the day treating a man, not a disease. Mm-hmm. So I think we combine everything in lack of those markers that we hope to get. We saw something at the ESMO. Mm-hmm.
Well, that's excellent. And it leads me into my next point. Unfortunately, despite the advances we've made in metastatic hormone-sensitive prostate cancer, castration-resistant disease is an eventual course for the vast majority of our patients. So, Dr. Schweizer, I'll ask you, how are you approaching metastatic castration-resistant prostate cancer, given the increasing multitude of treatment options we have in the current landscape?
Yeah, I mean, I think I'll say, first of all, I'm benefited by the fact I'm at an academic center, so clinical trials are always high on my priority list. But, in the absence of that, you're right. I think we've got a lot of options, which is great, but, it makes decision-making hard. We clearly know that for these patients who get upfront treatment intensification with an AR pathway inhibitor, an ARPI, that they're not going to have as great a response to a subsequent ARPI in that castrate-resistant setting. Response rates are lower. So drugs like enzalutamide after abiraterone, probably only 20-25% chance of a robust PSA response, for instance. I think, that being said, there are still a subset of patients who probably want that, either because of their goals, maybe they're low risk, low volume disease patients who, if it doesn't work, then you still have options of moving on to the next line of therapy. So I'll say in my practice, I do it for some patients. It sort of has to be highly selected though. But in the absence of like a low risk patient, I tend to sort of probably use docetaxel chemotherapy as one of my more common treatment options for those higher risk patients in the early castrate-resistant setting. And I think, it's interesting to sort of take that sort of framework into context with some of the data coming out of the presidential symposium today showing that radium-223 plus enzalutamide looks like it has better progression-free survival and, importantly, overall survival compared to enzalutamide alone. Now, I think it's important to understand that the patients who were enrolled in that study, by and large, did not have intensified therapy up front with an ARPI. So it may not be as applicable for many of the patients that I know I'm seeing in clinic. But that being said, if I have a patient who I'm otherwise thinking about enzalutamide, I'd be tempted to think about maybe adding radium-223 on top of that. Is it going to work for those patients? I think it's a bit of a data-free zone. At the same time, the combo is fairly well tolerated, so I don't think you're losing that much. And for somebody who their goal is to really try to be as aggressive as they can, albeit maybe they're not ready for chemo, it seems like a reasonable thing to consider based on these data.